Om Swastiastu. We are from SGD B1 from PSSKPD 2020 third semester. In this occasion, we would like to present our student project with title Stevens-Johnson syndrome. My name is Widya Amritha and I will start the presentation. Next. This is our group's members. Next. And this is our contents. Next. And I will start from the background. Introduction. At first drug reaction, or ADR, is a fatal and unwanted event or condition after normal drug administration in both dose and route of administration given for the prophylaxis, diagnosis, and treatment of a disease. The response to ADR can range from mild to severe and leading to death. One of the examples of severe ADR is Stevens-Johnson syndrome, or SGS. Stevens-Johnson syndrome is a hypersensitivity reaction associated with the presence of immune complexes with potentially life-threatening fatalities. The cause of SGS itself is unknown for certain, but it is said that SGS is caused by various factors or multifactorial. Next. And this is our problems formulations, such as first, what is the general overview of Stevens-Johnson syndrome? Second, what is the epidemiology of Stevens-Johnson syndrome? Third, what are the etiology and risk factors of Stevens-Johnson syndrome? Fourth, what is the pathophysiology and symptoms of Stevens-Johnson syndrome? Fifth, what are the diagnosis and differential diagnosis of Stevens-Johnson syndrome? Sixth, what is the prognosis and complications of Stevens-Johnson syndrome? Seven, what are the treatment and management for Stevens-Johnson syndrome patients? And eight, how to prevent Stevens-Johnson syndrome. Next. And this is our purpose of writing to answer the problem formulations. Next. And the benefits of our writing are give general and specific knowledge about Stevens-Johnson syndrome. And second, to understand the treatment and prognosis and prevention of Stevens-Johnson syndromes. That's all from me. Thank you. Next.
Okay, continuing what have been explained before. So my name is Dama and I would like to explain about the general overview. So first of all, Stevens-Johnson syndrome, or SGS, is one of an uncommon and crucial mucocutaneous disease which can cause multi-organ complication. It is occurred because there is a hypersensitivity reaction of type 4 due to a medication or drug eruption. This disease is characterized by erythematous maculae, which leads to central necrosis, lesion of bulbous, and painful epidermolysis because of the skin dying. So there's a scale called Total Body Surface Area, or TBSA, which is used to classify whether the patient is having SGS or TEN, which is the more severe condition of SGS patient. And the main principle in handling patient with SGS is by immediately stopping the drug consumption that caused the symptoms. So that's all from me. Thank you.
So I'll continue about the epidemiology of Stevens-Johnson syndrome, or in short SGS. So the prevalence of SGS is estimated around 1 until 10 cases per million annually. The prevalence of women with SGS and severe skin eruption is higher than men. Patient with immunocompromise, for example, in HIV patients, increasing 1,000-fold than general patient. So those are for comorbid, polypharmacy, and genetic factors can increase the risk of having SGS. So the drugs category that oftentimes become the main cause of Stevens-Johnson syndrome are antibiotics, anti-epileptics, and non-steroidal anti-inflammatory drugs, or in short, SAIDs. Next. So the incidence of Stevens-Johnson syndrome is different in several countries. So in United States, the rate of SGS is around 1.5 until 9.6 per million people per year. In France, 6.5 per million people per year. Next. In Singapore, there's a data that shows that cutaneous disease adverse drug reactions such as Stevens-Johnson syndrome have the rate of 0.7%, and in India, 19.5% patients with severe cutaneous adverse reaction are diagnosed with Stevens-Johnson syndrome. Next. The mortality rate of Stevens-Johnson syndrome is around 1% until 4%. That's all from me. Thank you.
Okay, my name is Maylenzky Devi Savita, and I want to explain about the etiology and risk factor about the Stevens-Johnson syndromes. Okay, the causes of Stevens-Johnson syndromes include infection, vaccination, drugs, systemic disease, and food. 50% of cases are related to drug exposure, and more than 100 different drugs are reported as the cause. Mycoplasma pneumonia also can cause SGS in children. Single drug treatment predicts drug causation in 60 to 70% of cases, and reactions occur between 4 to 30 days after initial exposure. Other causes include chemicals, immunizations, bone marrow transplants, and radiotherapy. Next. Okay, this is the risk factors about SGS. The first is occurrence of HIV infection. People with HIV have a 100% risk of developing SGS. The second is weak immune system. If you have a low immune system, a person will have a high risk of developing SGS. The third is previous history of SGS. A history of SGS related to certain drugs will increase the risk of recurrence of the syndrome if you are taking the same drug. Next. The fourth is family history SGS. If a close family member has SGS syndrome, you are more likely to develop it as well. And the last is genetic factors. Certain genetic variations can put you in increased risk for SGS syndrome. Okay, next.
Hello, my name is Gede Ngurah Winata with student identification number 225-11061. I will continue the presentation about pathophysiology of Stevens-Johnson syndrome, or SJS. In the early stage of disease, cytotoxic CD8 plus T cell preferentially infiltrate the blister fluid and the epidermis, where the CD4 T cell primarily infiltrate the dermis. The presence of soluble interleukin-2 receptor, a hallmark of activated T cell, highlights the role of activated cytotoxic CD8 plus T cell in the pathogenesis of SGS. When cell types were examined, it was shown that the majority of CD8 plus T lymphocytes were present in the blister fluid and skin biopsies. The majority of cases of SGS is altered by TCR-HLA interaction by drug-induced. There are three hypotheses have been offered to explain about it. The first is Prohapten model. Start with intracellular processing of the drug or metabolite, then covalent attachment of a peptide generated from a drug to endogenous peptide. This unique Prohapten is delivered by HLA class 1 molecule and identified by particular TCR on the cytotoxic T cell membrane. Second is pharmacological interaction with immunological receptor described by medication is non-covalent binding to either the TCR or HLA molecule to induce the T cell response in a peptide-independent manner, or PI concept. And the last is a kind of characteristic by chance peptide repair given by HLA molecule as a result of medication occupying and altering the HLA peptide binding graph or altered peptide. That is all from my presentation. Thank you.
So, my name is Amadeus Fernandito Leksana, and I will continue the explanation about the keratinocyte death. So, epidermal damage in SGS patients' skin lesions is thought to be caused by apoptosis. The triggering of keratinocyte death has been linked to the perforin or granzyme pathway, the fast ligand pathway, and the release of granulocyte. In the first scenario, NKT cells attach to their target cells and create granules containing perforin and granzyme. B. Perforin creates channels in the target cell's membrane, allowing granzyme B to enter and activate the cell's intrinsic apoptotic pathway. Second, when fast attached to a fast ligand on the surface of another cell, it triggers the intrinsic apoptotic pathway, in which fast ligand can also be released in the form of soluble fast or as fossil, which has a lesser apoptotic potency. There is conflicting evidence regarding the significance of fast ligand pathway in EN pathogenesis. FAS is expressed constitutively on keratinocytes and EN patients' serum and blister fluid containing greater levels of soluble FAS. And next. Okay, so next one is about the signs and symptoms. So SGS symptoms include photophobia, conjunctival irritation, dysphagia, and also cutaneous pain. Photophobia, conjunctival irritation, dysphagia, and skin tenderness follow the prodrome of fever and flu-like symptoms, which last about 1 until 3 days. Typical lesions are so-called dusky atypical targets, which are erythematous macules or papules with a dull or darkish center component, indicating epidermal necrosis and death. Over 1 until 3 days, individual target papules and larger areas of dark erythema consolidate into vesicles, bullae, or broad denule skin. Mucosal ulcers and erosion can affect the lips, mouth, upper respiratory tract, gastrointestinal tract, eyes, and genitals. Almost half of the patients had 3 mucosal sites implicated. The patient is ill, concerned, and in discomfort. Other organs can be affected by SGS or TAN, such as liver, kidneys, lungs, and bone marrow. This manifests some systemic acute malfunctions of organs that are involved, such as the ocular, pulmonary, cardiovascular, gastrointestinal, renal, and also hematological systems. So that's all from me. Next one will be presented by my friend.
Okay, my name is Bagus Manuaba, and I'm going to explain about the diagnosis of Stevens-Johnson syndromes. There are several tests and techniques to diagnose Stevens-Johnson syndromes, including medical history review. Specialists might recognize the SGS conditions depends on the clinical histories, physical examinations to find physical symptoms of SGS, skin biopsies typically taken to affirm the determinations to wipe out the other potential sources. Next. Culture. Skin and oral culture is extracted to affirm and preclude disease. Imaging. Specialists might run an imaging, for example, a chest X-ray beam to check for pneumonia. And the last one is blood test, is conduct to confirm infections or other possible sources. Next. Okay, the differential diagnosis for SGS is erythema multiforme major, staphylococcal scalded skin syndromes, generalized fixed drop eruptions, acute generalized exanthematose, bultosis paraneoplastics, and phototoxic eruptions. And the common drugs that trigger SGS, there are non-specific for SGS and specific for SGS. The non-specific one is granulocins and CCL27s, and the specific is galactin 7s and RIP3. Okay, that's all from me. Next.
Hello, my name is Kirana Chandra Putri, and I will explain about the prognosis and complication. So in non-severe cases of Stefanus syndrome, the progress is good and could heal within 2 to 3 weeks. But instead, the mortality rate ranges from 5 to 15% in severe cases with complications or late and inadequate treatment. One thing that is also associated with mortality is sloughing. So when sloughing in BSA is occurring below 10%, the mortality rate range becomes 1 to 5%. On the other hand, if the BSA sloughing is more than 30%, the mortality rate could be between 35 to 50%. Sepsis and bacteremia also play a major role in mortality increment. Next. So Scranton score could help to calculate mortality or the risk of death in Stefanus syndrome patients and toxic epidermal necrolysis by using variables such as age above 40 years old, having malignancy, and many more, which every variable equals in 1 point, and the more point a patient has, the more mortality rates they have. Persistent neutropenia, hypoalbuminemia, and persistent azotemia are also other negative prognostic factors. The epithelializations in Stefanus syndrome patients commonly complete in 3 weeks, but mucosal and precious areas could last crusted and also eroded for 2 weeks or more. Next. So Stefanus syndrome can lead to complications as well, such as complication in HEPA, renal, and also respiratory tract, ingenitourinary, penile scarring, vaginal stenosis, renal tuberous necrosis, and renal failure are the example of the complications. And the risk of having minimal 1 episode of perforations in the eyes or corneal perforations with post-Stefanus syndrome-led malignant keratopathy was 23.8% in adults and 18.3% in children. That's all from me. Next.
My name is Bertrand Wijaya, and I'm going to explain about treatment and management of Stevens-Johnson syndrome. The symptoms can become very acute and life-threatening if not treated. Stevens-Johnson syndrome has no particular treatment, so most patients are managed symptomatically. Treatment for Stevens-Johnson syndrome include replacing electrolyte with intravenous fluids, using non-adhesive dressings on the affected skin, consuming high-calorie food, using antibiotics when needed, providing pain relief medication, using the specialist team to undergo interprofessional assessment, and in some cases, are treated with IV immunoglobulin, cyclosporin, IV steroids, or amniotic membrane grafts. That's all for treatment and management of Stevens-Johnson syndrome. Thank you.
Okay, so now my name is Stevanus Surya, and I will explain about the prevention of Stevens-Johnson syndrome. So to prevent the development of Stevens-Johnson syndrome in a person, the next screening test may be considered. Asian and European ethnic people have a higher risk of contracting SGS because they have variations in the HLA gene of the types of HLA B15nil2, HLA B58nil1, and HBA B57nil1, HLB B13nil1, and HLA A31nil1. Next. So to prevent the recurrence of Stevens-Johnson syndrome, Stevens-Johnson syndrome is a type of disease that can recur. The recurrence of SGS tends to have more severe clinical manifestation than the first occurrence. The procedure of preventing the recurrence of each SGS conditions in people who have already been infected is to avoid taking the class of drugs that cause an SGS response. That's all from me. Thank you.
Okay, for the conclusion, the first, Stevens-Johnson syndrome is a rare and serious mucocutaneous hypersensitive reaction type 4. Which can cause multi-organ complication. Second, the prevalence rate of Stevens-Johnson syndrome is approximately 1 to 10 cases per million with people, with higher prevalence in women and 1,000-fold higher risk in immunocompromised patients. Third, etiology of SGS are mostly related to drug exposure. Fourth, CD8 plus and CD4 plus T cells are believed to have a role in the early stage of this disease. Fifth, two green drugs are known to interact with keratinocyte, human leukocyte antigens via three known models, haptens or hapten models, P1 concepts, and altered peptides. Sixth, SGS is diagnosed clinically, and additional tests such as skin biopsy, culture, imaging, and blood tests may be used. Seventh, there is no specific treatment for SGS patients, hence the majority of the patients are treated symptomatically. Yet the first steps in managing SGS is by cutting out any kind of drug that have induced the problem in the first place. These are reference. Okay, it's the end of our presentation. Thank you for your attention.